Assalamu alaikum. My name is Abdulellah, second year medical student, and I'm going to give you today, guys, a lecture about the male reproductive system. Before we start, رمضان كريم والله يكتب أجركم في هذا الشهر المبارك. Without any further delay, let's start. Before we start, let's have a quick guide. Whenever you see a white background, this is a new info, which is the lecture in general. But whenever you see a black background, this is going to be something recap, something just to refresh your mind with. So, okay, I guess you know the game right now. This is a black screen, so you know what's happening. So what's the function of the male reproductive system? But before that, what is fertilization? I'm pretty sure you guys are familiar with the concept fertilization more than me. But let's just recap, just to make sure that everyone is on the same page. Fertilization starts with a sperm that reacts with an egg, and this egg and the sperm reaction will result in the formation of a zygote. The sperm comes from a male, which is the father, and the egg comes from a female, which is the mother. They react with each other and form a zygote. This is the basic explanation and fundamental of fertilization. I think everyone is on the same page now. Let's dig into the concepts. Now, introduction to reproduction. Now we have a primary sex organ, and usually we call them gonads. And then it depends on the gender. If it's a male, we can say that those are testes. But if it's a female, we're going to say that those are ovaries. And they play a crucial function, which is in the production of sex cells and the synthesis and secretion of sex hormones, which is things that are fundamental for reproduction and the increase of the number of people. And now the accessory reproductive organs. Accessory reproductive organs, such as the ducts, glands, and external genitalia, we can call them secondary reproductive organs also. They function in quite a couple of functions, which is the development and function of the reproductive organ, to the sexual behavior and sex drive, which is libido. And libido, in simple words, which is the desire for sexual activity. And third is the growth and development of other organs and tissues. And now let's dig deep into the male reproductive organ. Main function, quite clear, which is the sperm production, and then the delivery or deliver the sperm to the female. Now that's a quite simple concept, which is that there's a sperm that's produced in the testes, and after the production of it will be delivered towards the female into the uterus to have a new forming fetus or human. And now the testes produce spermatozoa to fertilize the oocyte at conception to form the zygote. Now, for this lecture and for the simple concepts that we're going to be delivered, whenever you see spermatozoa, spermatid, spermatogonium, just imagine that this is a sperm. Later on, you're going to have a lecture about the spermatogenesis. They're going to define the different names for different stage and levels of the life cycle of a sperm. But for now, whenever you see any name, starts with an S, starts with a sperm, it's a sperm. Oocyte, ovum, egg, any name, it represents an egg, and zygote is known. So let's have a deal. For now, with this lecture, we have sperm and egg. Forget about any other name and any other life cycle names. And now the testes have two primary functions, which is the spermatogenesis and the steroidogenesis. Spermatogenesis, which is the sperm production, and then steroidogenesis, which is the synthesis of hormones. And in this case, we're defining the testosterone as in the process of steroidogenesis. Both function, which is the spermatogenesis and the steroidogenesis, are under hormonal control of pituitary gonadotropins. And pituitary gonadotropins are two, FSH and LH. FSH, which is the follicle stimulating hormone, and LH, which is the luteinizing hormone. Both of those hormones, the gonadotropins, are released by the gonadotropin releasing hormone, which is from the hypothalamus. In case you forget the concept of GnRH, let's have the black screen once again. GnRH, which is the gonadotropin releasing hormone, produced by the hypothalamus and function in the stimulation of the pituitary gland to release two things, FSH or LH, depends on all the other variables. I'm pretty sure you're fine with. And now with the FSH. FSH is produced by the anterior pituitary gland, and in males, it stimulates spermatogenesis in Sertoli cells. And LH, which is also produced by the anterior pituitary gland, also in males, it function in the stimulation or the synthesis of testosterone in the Leydig cells. Back to the white screen, we have the reproductive hormones. Reproductive hormones in general, we have the androgens, which are more towards the male, and estrogen and progesterone, which is for females. Those hormones, in general, the reproductive hormones or the steroid hormones, can cross the cell membrane. So another term, we can call them hydrophobic. Why they are hydrophobic? Why do we need them to be hydrophobic? Those hormones, the steroids, need to react with the nuclear receptors in the nucleus, so intracellular receptors. Whether in the nucleus or intracellular, regardless, but they need to cross into the cell. So the easiest way to cross is to go within the cell membrane. So that's why they should be hydrophobic to cross them. So they need to cross the cell membrane, so intracellular receptors or intranuclear receptors, and then they're going to affect the transcription factors. Now, those testosterones will be circulating in the blood. So to make sure that each and every hormone is affecting the designed and the target tissue, we have something that's called the SHBG, which is the sex hormone binding globulin. This hormone is responsible to bind for sex hormones or the steroid hormones whenever they're circulating. And let's just recall the function of those proteins that bind to those two hormones in general. Two main functions. One, to prevent excretion. So whenever they bind to hormones, they're not going to be excreted by the kidney. This is one. Two, those hormones will be in the inactive form when they're bound to proteins. So whenever they circulate within the body and goes to various tissues that they are not a target for them, they're going to be inactive and they will not be able to react with the receptors. Whenever they reach to the, let's say, the designed target or the target cell, at that time, we're fine and everything will be fine and they will be detaching from the protein and they'll be active in simple words. And now for the male sex hormones, which is, or male sex hormone without an S, it's the testosterone, is responsible for two characteristics, for the primary sex characteristics and the secondary sex characteristics. The primary sex characteristic, which is facilitate the formation, maintenance, and transportation of sperm. As we mentioned previously, one of the main functions of the testes or the male reproductive system in general is to synthesize or form a sperm, care about it, maturation of it, and then deliver it throughout from the testes all the way throughout the male reproductive tract until it reaches into the female reproductive tract and fertilize the egg. And then the secondary sex characteristics. And the secondary sex characteristics include typical male hair pattern, deep voice, and large muscle and bone masses. So anything that is used to define a male regarding the appearance, the physical characteristics, and how they develop is affected, and it's called the secondary sex characteristics. But what affect them and what form them? Indirectly, we can mention that testosterone affects that. But mainly, there's another form of testosterone, a derivative of testosterone, is called the DHT. DHT resembles the dihydrotestosterone. In this case, typically we need an enzyme that converts testosterone to DHT, which is the dihydrotestosterone. For the sake of time saving, I'll be calling the dihydrotestosterone DHT. But just be familiar, DHT resembles dihydrotestosterone. This enzyme is called the 5-alpha reductase. Now, for concept clarification, I think we need one whole slide for 5-alpha reductase. 5-alpha reductase is an enzyme that converts testosterone to DHT. I think we can agree on this point. Furthermore, there's two functions of DHT. One is before birth, the other one is during puberty. Before birth, we have the male reproductive organs development. But keep in mind, it's not the main effector of it. Mainly, testosterone is responsible for the male reproductive organs development. But DHT play a crucial role in it, but it's not the main one. The main one is testosterone. During puberty, the facial growth, hair growth, deepen of voice, formation of prostate, all of those are within the genre of secondary sex characteristics, and they're controlled by the DHT. Except formation of prostate is also affected by testosterone. But like prostate does not form fully until puberty, so DHT plays a crucial role in the formation of prostate also. So we can say that the roles of testosterone and DHT are not that distinct. There's a gray zone. So don't mix between them. There's a gray zone in the, but mainly some things are more towards testosterone. And just to have a clarified definition of the functions, we're going to say that the secondary sex characteristics are controlled by DHT, and the primary one is by testosterone. Whereas some gray zone, or there's a gray zone between them, but forget about the gray zone. And now, what if a 5-alpha reductase is deficient? So logically, whatever we mentioned previously in the slide, it's going to be, um, let's forget about it, it's going to be affected. So in this case, there will be no conversion from testosterone to DHT. So in this case, there's going to be ambiguous genitalia until puberty, while the internal male genitalia will be normal. So if someone is having a 5-alpha reductase deficiency, there's not going to be deep voice. There's the formation of prostate will be affected, facial health is affected, also the bone mass is affected. So any secondary sex characteristic of a male will be affected. Plus, there's an ambiguous genitalia, but the external genitalia will be affected. We're gonna furthermore mention what's the external genitalia and what's the internal genitalia, and what, let's say, the specific parts of the male reproductive system is considered internal and what is considered external. At this point, does anyone have any question regarding the part we discussed previously? Thanks. Okay. Furthermore, we have the male sex determination. Now, I think this is a crucial slide. Please focus on it. If you have any question, don't hesitate to ask. The male sex determinations. First of all, we know that we have XY and XX chromosomes. XX is for females. For this lecture, just forget about it. We're going to care about the XY. XY chromosome, which is designed for males, will contain a SRY gene that's found on the Y chromosome. This SRY gene will result in the differentiation of the gonad that we mentioned, it's the primary sex organ, will differentiate into a testis. The fetal testis is affected, the differentiation is affected by SRY gene and Y chromosome. And then this will result in the formation in two types of cells in the gonads or the fetal testis, which is the Sertoli cell and the Leydig cell. Let's start with the Leydig cell. Leydig cell is responsible for the production of testosterone. By the production of testosterone, this will activate the Wolffian duct. This is the Wolffian duct. The Wolffian duct is responsible for the formation of the male reproductive organs. The Wolffian duct will differentiate into 4 different structures. 1, which is the epididymis. 2 is going to be the vas deferens. And 3, the seminal vesicle. And 4th, which is the ejaculatory duct. Keep them in mind. You may be asking about an MCQ, which is the following is a derivative of Wolffian duct, and the doctor throw 4 wrong choices, and the 5th one is the correct. So keep in mind that the Wolffian duct is responsible for the formation of the internal male genitalia. So those 4 structures are considered internal male genitalia. And now for the derivative that we spoke about, which is the DHT, the dihydrotestosterone. I'm pretty sure you guys, you know what's the enzyme. It's 5-alpha reductase. So 5-alpha reductase is responsible for the conversion from testosterone into dihydrotestosterone. The dihydrotestosterone is responsible for the development of the following structures: of the penis, of the scrotum, and the prostate. So keep them in mind, those are the external male genitalia except for prostate, but penis and scrotum are considered the external male genitalia. And now let's go to the other side for the Sertoli cell, which is the other type of cell. Sertoli cell, S for S, like link it that way. Sertoli cell is responsible for spermatogenesis, which is S also. Just keep this in the back of your mind for the upcoming slides. Now, the Sertoli cell will release an important enzyme or hormone, I'm sorry, that will regress the Mullerian duct, which is the anti-Mullerian hormone. It's quite simple. Mullerian duct is inhibited by the anti-Mullerian hormone. Now, the good question here is, what's the Mullerian duct? The Mullerian duct is the duct responsible for the formation of the female genitalia. So I guess by now, you had an overview of the sex determination. But one important point that you need to master in this slide before you move on, because it's going to help you in not only in this lecture, in the female reproductive system lecture, and also in the lectures where you're going to have defects. Typically and normally, the Mullerian duct is activated and the Wolffian duct is inhibited. So we can say that normally, if there's no effect by any external factor, the end product of the fetus is going to be a female. We can say yes. When in which case we can have a male if there's a Y chromosome that contains the SRY gene, SRY gene that results in the differentiation of the gonads into testes, and those testes will release a anti-Mullerian hormone that inhibits the Mullerian duct that is typically activated, and release testosterone that activates the Wolffian duct that is typically inhibited. So it activates the inhibited one and inhibit the activated one to form a male. In some defects, later on you're going to take them, where sometimes the Wolffian duct is kept inhibited, and also the Mullerian duct is inhibited. And sometimes the Mullerian duct is inhibited and the Wolffian duct is not. So there's a overlap between the functions and in some defects. So make sure just to master the physiology of them. Okay, and whatever we mentioned is in the transcribed form here. Now for a quick anatomy of the male reproductive, I'm pretty sure you had a more detailed lecture, but for the sake of this lecture, we're going to give you guys a quick recap and description of the male reproductive anatomy. We'll start with the testes, with the smallest functional unit, which is the seminiferous epithelium. And within the seminiferous epithelium, it's along, let's say it's a convoluted rope or convoluted pipe that it's called the seminiferous tubule. And the seminiferous tubules are divided by the septa into form small functional units, similar to the idea of what you have in the liver, in the liver also, and in the lung, those septas and those functional units. Also in the testes, there's the septas that divide the seminiferous tubules into independent functional units. Those seminiferous tubules going to form the sperm. Regardless of the name stage, we told you guys in this lecture, just forget about the name stage. Upcoming lectures, you're going to care for them. This will carry them from the seminiferous tubules to the rete testes, and from the rete testes into the head of the epididymis. And there we're going to have a maturation process where they're going to be more motile, or they're going to be motile because they're non-motile, and then you're going to be stalled. Whenever there's a ejaculation event, they're going to move from the epididymis into the tail of the epididymis and then into the vas deferens. And the vas deferens, they're going to move through a long, let's say, pipe or a pathway until they reach to a place where the ampulla forms. Next slide, I'll show you what's the ampulla, but just keep in mind there's an ampulla, which is a widening of the tract, joins with the seminal vesicle, and as they joins, they form the ejaculatory duct. The ejaculatory duct is within the prostate, and then they join within the prostate and enters the prostatic urethra. And then from the prostatic urethra, they go down into the penile urethra and then into the bulbar urethra, and then they leaves the penis from the glans penis opening. Now, a good point just to mention here for the sake of completion, I'm pretty sure guys you're all familiar with the concept of the internal urethra sphincter. Physiologically and normally in the events of ejaculation, where there is a expelling of the sperms outside of the testes and then outside of the penis, the internal urethra sphincter physiologically and normally should be contracted and closed. So there's no retrograde ejaculation. If the internal urethra sphincter is weak or not closed properly, then there's going to be retrograde ejaculation, which is a serious case and should be avoided. And now with the functional structure of male reproductive system, I'd like just to mention quite things that those are the convolutions of the seminiferous tubules here, where they form one pipe that goes into the rete testis area. This is the rete testis. And then it goes into something that's called the efferent ductilules, and then it links them with the epididymis. There's the head of the epididymis, and then down there we have the tail of the epididymis, and they're going to pass into the vas deferens, and then from the vas deferens, this is the ampulla. That's what I'm showing you guys. This is the ampulla where it joins with the seminal vesicle. So this is a space where there's a mix between the sperm and the viscous material and the transient material that is released by the seminal vesicle. They mix here, and then they enter the ejaculatory duct that is formed by the conjoining of the vas deferens and the seminal vesicle. And then they complete their pathway smoothly through the ejaculatory duct, and then the prostatic urethra, down to the penile urethra, and then the bulbar urethra, and then they leave through the glans penis opening. One more thing to mention in this slide, it's the bulbourethra gland. Also, I think it's called the Cowper gland, where it has a quite important function we'll discuss later in this lecture. Okay. And then we have the functional structure of male reproductive system. This is also the transcription of whatever we discussed in this slide, and also those two slides. Okay, and now let's move to the scrotum and the structure of the testes. Now, what's the scrotum? The scrotum is sac of skin, superficial fascia that hangs outside the abdominal pelvic cavity. A lot of words, yes? In simple words, bag that holds the testes. Let's go back into the image. This is the scrotum. This is it's a skin. It's part of the skin, the outer skin, that holds and protects the testes, and also does not have a function of protection. More functional. Let's discuss them. So mentioned, it's a bag that holds the testes. So also it can pair testes, of course, just to mention, they have contains pair testes, which is 2. So for temperature, the testes should be kept in a temperature lower than 3 degrees Celsius. What do I mean? That the 3 degrees Celsius lower than core body temperature necessary for sperm production and spermatogenesis. Then what happens during fever? We're going to discuss this. Like typically, if we need a specific temperature and then the body temperature has changed, so this is going to affect some physiological processes in the body. But now, what keeps the testes temperature constant? One, we have the dartos muscle. Dartos muscle is a smooth muscle, and the sake that we mentioned why it's a smooth muscle, because it's an involuntary muscle, so this is a reflex within the body. So this muscle have let's say two movement, whether wrinkles scrotal skin, where it contracts and brings the scrotum more towards the core of the body, and this in the case of low temperature. So to increase the temperature of the testes to meet a 3 degrees Celsius difference than the core of the body temperature. Whereas in high in environments where the temperature is high, the dartos muscle relaxes. So with the relaxation of the dartos muscle, this will result in also controlling the 3 degrees Celsius difference than the core of the body. So key concept here, dartos muscle controls the testes, the scrotum, I'm sorry, it does not move the testes. It's a secondary movement because mainly it contracts the scrotum and results in its retraction or expelling it, retraction or just pulling it towards the body, the core of the body in terms of low temperature, and then relaxes in terms of high temperature. But wait a minute. Okay. And then we have the cremaster muscle, which is skeletal muscle. So it's a voluntary muscle. It helps in the elevation of the testes. So this is the cremaster muscle. It's a layer of muscle that surrounds the testes. So it allows the anyone to elevate or de-elevate. Or sorry, it's just elevating. So it just elevates the testes. And now another concept that helps in the management and the control of a constant temperature of the testes is the pampiniform plexus. Then what's the pampiniform venous plexus? The pampiniform venous plexus is a collection of veins that collects blood from the testes and send it away and towards the heart. So what happens here, and this is a quite important concept to be familiar with, you may ask about in MCQ. We have here the testicular artery. Imagine my hand is the testicular artery, which is full of oxygenated blood going towards the testes. But this blood is hot, is hot compared to the temperature of the testes. As we mentioned, we need to control and to have a difference of 3 degrees Celsius lower than the body core temperature. And this blood probably is high, temperature is higher than the testis temperature. So what happens, there's a blood that is coming back from the testes towards the heart. And this is called the pampiniform plexus, which is the veins in general. But because they have a lot of connections between them, we call them a venous plexus, and it's called pampiniform plexus, surrounds the testicular artery. So imagine blood that's full of heat is going downward, and then blood that's cold going upward. Basic physics, heat's gonna move from high temperature to low temperature. So the temperature in the blood in the testicular artery will move toward the blood in the pampiniform plexus. So the temperature of this blood will decrease. So this is called a counter-current heat exchange. So a counter-current heat exchange results in the decrease in the testicular temperature to maintain a 3 degrees Celsius difference than the core temperature of the body. And now in terms or in cases of fever, so if there's fever or thermoregulation dysfunction, this may cause sertility. Sertility, which is the the, let's say, impaired spermatogenesis or failure of spermatogenesis. So in events of fever, which is increased temperature, so there is no constant control of the 3 degrees Celsius difference between the testis temperature and the core temperature of the body, impaired spermatogenesis in these Sertoli cells. We say it S for S. But the steroidogenesis, which is the synthesis of testosterone, will not be affected, which is in the Leydig cells. So keep this concept in mind. In high temperature fever or when the temperature is unregulated, spermatogenesis is affected, whereas steroidogenesis is not affected. Moving on, we have the testis structure, the seminiferous epithelium. Guys, I need you to focus on the upcoming 3 lectures, 3 slides, I'm sorry, quite related to each other, so just be familiar with the concept. Now, just familiarize yourself with the image. This is a cut from the testes. We have here the lumen, where the synthesized sperms will go into it and then moves towards the epididymis, whereas this is the basal lamina, where we have here the blood vessels, the Leydig cells, the myoid cells, which is the muscles that contract, and then we have interstitial cells. Now we oriented yourself with the image. One more thing to mention, this is the Sertoli cell, as you can see, and it's surrounded by different states of maturing sperms are approaching maturization. So those are considered sperms, but with different shapes and different stages. As we mentioned, for the sake of this lecture, ignore the naming, and later on in the spermatogenesis lecture, focus on them. Now just get the concept. So we have the testes had around 300 lobules with 1 to 4 seminiferous tubules, making up 80% of testicular mass. The tubule is lined by Sertoli cell forming the walls of the seminiferous tubules, with Leydig cells in the interstitial region. So what's meant by here, that we have here the Sertoli cells are surrounding the sperms. So it functions, the Sertoli cell, as is seen in function in maturizing, supporting, protecting the maturing sperms. And then we have the basal lamina that separates the maturing sperms from the body. And then you have a crucial point regarding the immune system will be mentioned in the upcoming slides. And here we have the luminal side. And now we have the important concept, which is about the blood testi barrier, which is the BTB. And this is a barrier that's formed between the normal body or the body itself and then the maturing sperms. And this barrier is maintained by the tight junctions. Another image will show you exactly where's the tight junction and why it's there. But for now, quiet points, keep in mind, we have steroids and paracrine proteins pass the barrier to regulate function between Sertoli and Leydig cell. As we mentioned, we have some FSH and LH acts on Leydig cell and Sertoli cell respectively. So we need those steroids, we need those paracrine hormones to act in those cells to control their function, whether activating or inhibiting. And then we have the fluid in the lumen of the seminiferous tubules has little protein, but have rich in androgens. So keep those points in mind. We have little proteins and glucose, whereas we have high and rich and high levels, and the luminal side is rich in androgens and estrogen, also potassium and other components, but mainly focus on androgens. Now, this is the image that I meant. This image is just upside down. So here's the basal part where the Leydig cells is here. We have the blood vessels here, the capillaries, whereas down here we have the lumen where the partially fully synthesized sperms are here. So quite concept to be mentioned here. This is the tight junction. Why is the tight junction placed here specifically? We mentioned that we need to separate these body cells from the synthesized sperms, and mainly to separate the synthesized sperms from the immune system. Why do we need that? Our cells are let's say, identified by the immune system as friendly cells, self cells, let's call them, like from the same, they're self cells, they're related to us. But the immune system identifies the developing sperms as non-self. Why? Typically, the body cells are 46 chromosomes. Agree on that? Yes, I'm pretty sure you agree with me. But the sex cells, after a specific stage, after the division of the spermatogonium into spermatocytes, this will result N, forming a 23 cell chromosome, which is the sex cell, which is half the number of chromosomes. In this case, the immune system, if it finds any sperm, will consider it an invader, non-self cells, as you mentioned. So we have the body cells, self cells, and the sex cells are non-self cells. How to separate them? The blood-testis barrier. So at this tight junction, at this stage specifically, we have a separation between the spermatogonium, which is still a 46 chromosome cell, whereas the spermatocyte, the primary spermatocyte, which is a 23 chromosome cell. So the tight junction at this point separates them to prevent the immune system from going beyond the level of the tight junction towards the lumen. And then it's located between Sertoli cells are dividing Sertoli cells are dividing germ cells. Germ cell represents those, the spermatogonium, the spermatocytes, the six cells that are dividing. So spermatogonia divide the basal compartment. So now we have a part that's called the basal compartment and the abdominal region. What divides them specifically? Link it to the tight junction. Whenever you see the tight junction, before it towards the capillaries and the basal lamina, we call it the basal compartment. Logical, I think. And then tight junction, whatever it comes after it or beyond it towards the lumen, is called the abdominal region, where the immune system can't reach because of the tight junction that forms the blood-testis barrier. Does anyone have any questions regarding this part? Is it clear? Pretty clear. I wish it's pretty clear. Don't hesitate to stop me at any point. طيب. Endocrine regulation of Sertoli cells and Leydig cell. This is a high yield concept and a kind of a tough slide. So please pay attention. So let's start with the Leydig cell. In the Leydig cell, we have the LH that reach into its receptor and bonds with it. When LH binds to its receptor, it results in a sequence of intracellular reactions. Those reactions will activate the release of cholesterol from its storage. When cholesterol is released from its storage, it results in the formation of testosterone. How does it form? Let's say just wait a minute. For now, we'll discuss this in the upcoming slide. But for now, just keep in mind cholesterol is converted into testosterone when LH binds to its receptor. When LH is synthesized, it needs to go to its designed target. So some of testosterone goes into capillaries and then into circulation to affect some peripheral tissue and convert it into DHT. So it's not our topic right now, but just go to the second arrow of testosterone, the one that goes into the Sertoli cell, the cell that is specific for the synthesis of spermatogenesis. So Sertoli cell requires high levels and high concentration of testosterone to initiate the process of spermatogenesis. But that's not the only thing required. It requires also the presence of FSH binding to its receptor. So FSH approaches, binds to its receptor, results in intracellular reactions through the G protein. With that, it results in the activation of spermatogenesis. So two things are required for spermatogenesis. One is increased testosterone percentages or concentration in the Sertoli cell. Two, FSH. But that's not only the function of FSH. Also FSH results of the conversion of testosterone into estradiol through the acting of cyclic AMP, the activation of cyclic AMP. That's the case, totally or in general, that's the case. One last point in this slide, which is the ABP. ABP, which is the androgen binding protein, is quite similar to the SHBG, which is the sex hormone binding globulin, but this one is specific for androgens, the name suggests. So androgen binding protein binds to testosterone as it's an androgen, 1, 2. So androgen binding protein binds to testosterone. So it ensures the correct circulation of it within the cell or within the testes in general. Everything we mentioned was transcribed here. Also the slide, both two slides related to the whatever we mentioned previously. And now for the steroidogenesis. We mentioned in that slide regarding the LH binding to its receptor, it results just in cholesterol releasing and then convert it to testosterone. Honestly, I wish that was the case because it's going to be simple. But this is the real case. That's what's going to happen. LH approach to its receptor binds to the LH receptor. This will result in activation of intracellular reactions accompanied with a G protein, so ITP converted to cyclic AMP, adenyl cyclase activation, and then protein kinase. Protein kinase, when it's activated, it results in the release of cholesterol from its storage. Releasing of cholesterol from its storage will result in it approaching it to the mitochondria. In the mitochondria, there is a conversion of cholesterol into pregnenolone. Pregnenolone is furthermore carried to the smooth endoplasmic reticulum. In the smooth endoplasmic reticulum, there is a sequence of reactions that results in the formation of testosterone, and then testosterone is released into whether the blood circulation or sent to the cytosol. I know in this case, he took furthermore, but in lecture, Abdul Jabbar, he mentioned those points. He skipped those enzymes. But I know that specific lecture, and I think Dr. Ahmed Yaqeen, he mentioned those enzymes and gave you specific abnormalities. So don't skip them. But for the sake of this lecture and the explanation of Dr. Abdul Jabbar, he skipped them. But you may have them in the exam. And this is probably this is the transcription. So if you can go over them. And now the male duct system. We'll start with the epididymis, of course, just to give you an overview of the male duct system. It's what carries the, let's say, the sperms from the testes all the way to where it binds or just joins with the urethra. So first we're going to have the epididymis, and then the duct is different, or another word's called the vas different, and finally the ejaculatory duct, where it's going to join the prostatic urethra later on. The epididymis, which is the first part, the sperms, let's say, just stays there for a specific period of time before ejaculation. It's an area of late maturation, let's say. So it contains a head part, and the head part contains ciliary muscles, or ciliary movement, I'm sorry, muscle contraction, and flow of fluid that allows movement of sperms. Why do we have a flow of fluids that allow movement of sperm? Because at that level, at that stage, when the sperms enters the epididymis, they are fully mature, except from one side, which is the motility. They're not non-motile. So we have microvilli absorb testicular fluid and pass nutrients to stored sperms. So the non-motile sperms become motile as they pass through. So this is one of the main functions of epididymis, which is the late maturation of sperms. And then during ejaculation, the epididymis contract, expelling sperm into the vas deferens. What makes the epididymis contract is the convoluted structure within it. So there's a contraction process, as mentioned here. There's a muscle contraction to push and expel the the sperm out of the epididymis. When it's let's say pushed or expelled out of the epididymis, it's going to go to the vas deferens, and then the journey continues. But at this point, it just pushed out of the epididymis. And then the sperm spends approximately around 20 days in the epididymis, and it's one of the stage of spermiogenesis. So this is spermiogenesis, whereas, sorry, we kept mentioning spermatogenesis, but this is spermiogenesis, which is related to motility, increasing motility of the sperm. You're going to take this more details in the spermatogenesis lecture. But for now, just keep in mind that there is a maturation process, or a late maturation process, let's call it, in the epididymis to convert the non-motile sperms into a motile sperm. Okay, and then we have the male duct system. Furthermore, we have the vas deferens. The vas deferens passes through the inguinal canal. And like the first starting point, let's say, of the vas deferens is where we have a termination of the لا إله إلا الله epididymis. So as mentioned, we have the epididymis, we have the head of the epididymis, and then the tail of the epididymis. As that ends, we start with the vas deferens. The vas deferens moves all the way from the testes or from the end of the epididymis until it reaches the seminal vesicle, where it joins the seminal vesicle and forms the ejaculatory duct. Before that, there's a specific structure that forms, which is called the ampulla, where there's a quite like a partial stop, a temporary stop for them milliseconds, just to mix the fluids synthesized or released from the seminal vesicle with the sperm to form the semen. So at this point, we have something that's called the semen, which is the mixture between the sperms and the transient viscous material released by the seminal vesicle and other glands such as the bulbourethral gland. تمام. The slide, تمام. ممتازين. Okay. Forms the ampulla and joins the duct of the seminal vesicle to form the ejaculatory duct. Also, it's the main, or it's the only way to connect the epididymis to the urethra. So it's the longest pathway connection for the male duct system. More of a concept mentioned in the lecture, which is the vasectomy. Vasectomy, it's a surgical procedure to the ligation of vas deferens. As we mentioned, the male system have only one pathway that sends or delivers the sperms from the epididymis or testes all the way to the urethra to join and then leaves. So if this pathway is affected or damaged, this will affect the process of carrying the sperms, and there would be no ejaculation in that case. So in the case of vasectomy, some people tend to ligate the vas deferens, and sometimes it's done because of these incidents of trauma. But a third thing is because of some congenital diseases. So something which is related to cystic fibrosis. Some men is born with cystic fibrosis have azoospermia. Azoospermia, that there's have congenital bilateral absence of vas deferens. As you mentioned, the only pathway from the testes to the urethra is the male duct system, which is composed of epididymis, vas deferens, and ejaculatory duct. Some patients, male patients, are born with congenital bilateral absence of vas deferens. So there's no pathway that carry the testes, or sorry, carry the sperms from the testes all the way to the urethra to result in ejaculation. So this is a serious case that we should be managed. And now this is a visualized image to specify the male genitalia. So we start with the epididymis. We mentioned it's responsible for maturation, to form motility, to have muscle contraction, and also secretion of specific fluids of the testicular fluid. Also, it results in hydrogen ion secretion. So the pH level at this area is tend to be low. Also, furthermore, we have the vas deferens here, the seminal vesicle, and then the ejaculatory duct. Now we have three structures that we'll discuss furthermore, but just a quick overview of them and their positioning. We have the seminal vesicle, one that joins with the vas deferens to form the ejaculatory duct. Then we have the prostate, which is the small structure found below the bladder, which is specific for some function we'll be discussing. And then we have the Cooper gland, which is the bulbourethral gland, which is also responsible for secreting some fluids that helps in the process of ejaculation. Let's start with the prostate, which is one of the important organs that's special for males. This organ or this structure is encircled part of the urethra. So as you know that there's a prostatic urethra. So it's encircled, this prostatic urethra is encircled within the prostate. But that's not only pathway that is encircled. Also, there's something that we call as the ejaculatory duct. Ejaculatory duct, which enters through the posterior, let's say posterior superior, posterior part of the prostate, and then joins the prostatic urethra where the semen passes through during ejaculation. So the prostate contains and secretes citrate and also specific enzymes, and also the PSA. The PSA, which is the prostate-specific antigen. For now, just know that the PSA is secreted from the prostate. Later on, you can know that some diseases, some specific diseases, is tested and is diagnosed according to the levels of PSA. So in specific diseases, patients tend to have high levels of prostate-specific antigen. And then it function and activation of sperms, and also fibrinolysin. At this point, it's really important we speak about the fibrinolysin, is responsible. So the name suggests lysin, which is something that you lysis something, you break it down, and fibrin, so you break down fibrin. So it happens during ejaculation, and when ejaculation happens, some semen tend to be coagulated because of specific coagulating factor released. So after ejaculation, it's not logical and to have those semen, the coagulative semen, kept there because they're blocking the pathway regarding if there's a upcoming ejaculation event, second ejaculation event, or just for the passage of urine. So the prostate, after 15 to 20 minutes after ejaculation, tend to release fibrinolysin to make sure that any coagulated semen during the ejaculation process is removed to clear the pathway, let's say for any upcoming ejaculatory event or for urination events. So fluid enters the prostatic urethra, that's one. And also during ejaculation, sorry, there's an issue with the wording, it enters the prostatic urethra. and there's the ejaculatory duct. So they're not one thing. We have the prostatic urethra. So this is the prostatic urethra from the bladder all the way to the penile urethra. Whereas the prostatic urethra is this segment that links between, let's say, the urethra itself and the reproductive tract that sends the semen and sperms from the testes all the way to join the urethra and then gonna be ejaculated. And now another accessory gland, which is the seminal vesicle. The seminal vesicle produce viscous alkaline seminal fluid. And something really important that is produced by the seminal vesicle, which is the fructose. Fructose is important for motility. We described previously in the previous slides that motility and converting non-motile to motile sperms is done by epididymis. So this is essential and crucial for the function of the sperm. But we need to activate the motility function, and as you know, the sperm need to swim, let's say in simple words, from as it enters into the female reproductive tract from the vagina all the way to the uterus and then the fallopian tube to have fertilization. So fructose is required to supply the sperm with energy so it can swim. And then there's also ascorbic acid, coagulating enzyme, and also the prostaglandins. Also, 70% of the volume of semen. So it's functioning so it composes, or the composition of semen, 70% of it comes from the seminal vesicle, from the fluid that enters. Those sperms itself amount compared to the overall volume of semen is a minority or minor. Duct of seminal vesicle joins the ductus deferens to form the ejaculatory duct. I guess this point we came over to multiple times, that the seminal vesicle, or let's say the vas deferens, joins the seminal vesicle and forms the ejaculatory duct when it enters into the prostate. And then we have the bulbourethral gland, which is a small gland, but function in some crucial steps in the process of ejaculation. First, it's a pea-sized gland, and then it's inferior to the prostate. So you have the bladder, and then the prostate, and then the bulbourethral gland, other name, which is the Cowper gland. It's prior to ejaculation. Why? Because it releases or produce thick, clear mucus. This mucus function in lubrication of the glans penis and neutralization of acidic urine acid. So lubrication, the concept or the term simplifies or signifies that we need to lubricate the tract or the channel, so to ease the process of ejaculation and also to neutralize the tract from any urine or any increased pH level. So because the sperms or the semen in general is affected by high pH levels, or sorry, low pH level acidic urethra, when the acidic level of urethra is high, so we need to neutralization. So this is done by the bulbourethral gland. Now with the semen. The semen, which is a mixture of sperm, so the sperm is around 10% of it. We mentioned that 70% of the semen comes from the seminal vesicle. Probably, doctor, we're not gonna ask about numbers and percentages, but it's nice to be familiar with the percentages, or like just more or the highest or the majority of the volume or composition of semen is coming from the seminal vesicle, whereas just the sperm is around 10%. And then also the semen contains fructose. Fructose comes from the seminal vesicle. It also protects and activates sperms and facilitates their movement. Prostaglandins in semen. Also, there is prostaglandin in semen. The function of prostaglandin in semen is of what comes after ejaculation, because the journey does not end with ejaculation. It ends with our lecture today with ejaculation, but it continues towards the female side, the female reproductive organ. So prostaglandin is required for specific bacteria found in the female reproductive tract for the protection of their reproductive tract. But in the case of fertilization, we need something that we know, okay, we need to pass this semen or sperm towards the side of the female. So prostaglandin works on specific bacteria there to inhibit them so it can pass the sperms. So decrease the viscosity of the mucus in the cervix. So the cervix is part of the uterus of the female. So there is a mucus there, a viscous mucus. So we need to decrease this viscosity, so the sperm can pass, because of specific parts of the menstrual cycle, different viscosities, but in general, it functions in decreasing the viscosity. It also stimulates the reverse peristalsis in the uterus. This function, because normally, the peristalsis movement, which is that the the worm movement where it pushes. So normally they go towards the gravity, but in terms of when the semen enters, specific enzymes and proteins within the semen results in the activation of reverse peristalsis. So it helps in the journey and the traveling of the semen upward towards the fallopian tube. And then we have the alkalinity and neutralizers. So the acid in the male urethra and the female vagina. And that's mainly when those enzymes are released by the bulbourethral gland, as you mentioned, for neutralizing acidic urine. And then we have antibiotic and chemical destroys bacteria. This is also crucial to enter to the female reproductive tract. And then we have the clotting factor. Clotting factor, which is coagulate semen after ejaculation. So, okay, sometimes semen because of this clotting factor, not all of the semen leaves the male reproductive tract. So some of them get to be clotted, or there's a coagulation within the tract. So to clear the tract, we need to have a breaking down enzyme, which is the fibrinolysin, that liquefies the the semen 15 to 20 minutes after ejaculation. And then those are more other numbers, like 2 to 5 milliliters of semen are ejaculated, containing 20 to 50 million sperms per milliliter, which is a quite big number. So this slide is just a collective explanation of the three parts or three glands that we discussed, the accessory glands. So it's a good collective revision for the three glands. And then quite numbers mentioned by the doctor. So for the sake of completion, we're going to mention them. So we have volume, which is more than 1.5 milliliter. pH is more than 7.2. Total sperm number, 40 million sperms or more per ejaculation. Morphology, more 4% normal forms. So regarding those numbers, just familiarize yourself with. Don't memorize them. Don't bother yourself with. I don't know if he's going to ask, but normally doctors don't ask about those things. But in case, just go over them to be familiar with. And then let's discuss the penis, which is an external part of the external genitalia. So the external genitalia is composed of two things, the scrotum and the penis. So penis consists of root and shaft. This is the root of the penis. So the specific part that leaves the body, or the initial part outside of the body, whereas as it continues, as it elongates, we have something that's called the shaft of the penis, or the body of the penis. So basically, body and root. The one that comes first is the root, and then the shaft, which is the body of the penis. And now there is a specific structure that's called the precore, or the foreskin of the penis. So it's a loose skin covering the glans penis. This is something that usually newborn males are born with. So it should be cut down because of surgical practices and religious practices. So there's a procedure called the circumcision, which is the surgical removal of the foreskin. So typically it's a part of the penis, but as soon as the fetus, a male fetus is born, it used to be ligated, or I'm sorry, it's just a removed with surgical removal. So it's called the circumcision. Now with the spongy urethra. Within the spongy urethra, which is the continuation of within the penis, we have three cylindric bodies. So two of them are in a group and one is in a group on its own. So those are three cylindric bodies of the erectile body. So they are responsible for erection. So what's erection? It's the changing of the normal position of the penis from relaxed state into a steady by state for a upcoming uh, sexual procedure and ejaculation. So we have the three cylindric bodies. We have first the corpus spongiosum. So the corpus spongiosum, it's a one body, so surrounds the urethra and expand to form the glands and the bulbs. So this is the corpus spongiosum, which is one that surrounds the urethra. What's the significance of it? To keep the urethra opened. Why to keep it open? Because we have another two cylindric structures, which is called the corpora cavernosa. The corpora cavernosa are paired dorsal erectile bodies. The function of those are during erection, which is the changing of the normal physiological appearance of the penis from the relaxed state into the stretched stage. They're filled with blood. So whenever they're filled with blood, they may close the urethra. To ensure that the urethra is not affected, there's the corpus spongiosum that expands and makes sure that the urethra is open throughout the process of erection. So to sum up this slide, we have three cylindric structures. One, which is the corpus spongiosum, which is the one responsible and surrounds the urethra, responsible for keeping the urethra opened. Two, we have the corpora cavernosa. The corpora cavernosa, we have two, so it's paired, and they're dorsally found. And those two structures are called the erectile bodies. They are filled with blood during the process of erection. And then we have the reflex pathway of penile erection. Now we knew what's meant or what happens during erection, and we need to know what causes erection. So it begins from two inputs, whether if it's mechanoreceptors, sensory ones on the penis, or there is a descending CNS pathways triggered by thoughts, emotions, and sensory inputs, such as smell and sight. So there's two types of inputs, whether mechanoreceptors or whether thoughts and emotion and sensory inputs. Those will affect the neurons and will go to the neurons of the penis. And this will result in the activation and the increased activation of neurons that release nitric oxide. What's nitric oxide and what's the significance of nitric oxide will be discussed in the upcoming slide, but just know now that when with the activation inputs, whether from the CNS or from the mechanoreceptors on the penis itself, will result in the release of nitric oxide and also the decrease of the sympathetic activity. So we can know that this is a parasympathetic activity, but not a complete parasympathetic activity. There's an overlap between the parasympathetic and the sympathetic systems, but will be clarified towards the end of the lecture. And now, towards the side of the penis, there's a dilation of arteries. As we mentioned, we have the corpora cavernosa, which is the paired erectile bodies. Those bodies, each one contains an artery. This artery is dilated first and then filled with blood. So this is what brings erection. And then those veins, or the veins that are responsible to let's say drain or just empty the penis from blood, or those erectile bodies from blood, they'll be compressed and closed. So imagine that blood is going in and then blood is not leaving. So blood is accumulating, increased number of blood. So there is a dilation, widening of the arteries. So this brings erection. Now, this should have let's say, a subcellular function or subcellular process that should be led. And that's where we go take. أول شيء معلش, this is the transcription of the previous slide. And now, the molecular mechanism of male erection. What happens, as we mentioned, we have a stimulus. And the stimulus could be whether mechanoreceptor or descending from the CNS, whether by emotions, whether by smelling, by sight. Those are the stimulus. This stimulus gonna bring up a specific uh, um, product or neurotransmitter that is released, which is the nitric oxide. The nitric oxide function and the activation of the guanylyl cyclase. The activation of the guanylyl cyclase will result of the conversion of GTP into cyclic GMP. Cyclic GMP results in the relaxation of the smooth muscles. As the smooth muscles of the blood vessels relaxes, this is going to increase the blood flow into the cavernosus, the corpora cavernosa. So this is the corpora cavernosa with the increased nitric oxide. This increases the GTP, and then GTP is converted into cyclic GMP. Cyclic GMP brings the relaxation of the blood vessels, the smooth muscles of the walls of the blood vessels. So the blood flow increases. When blood flow increases, there's a increase in the volume of blood in those specific arteries in the erectile bodies. So this will bring erection, but that's not the only way to bring erection. Also, there is another pathway that goes and results in the contraction of muscles around the base of the penis. So to point out those muscles, this is the root or the base of the penis. Around it, there's a couple of muscles. At this point, nothing is mentioned about, no need to know. There's a group of muscles around the base of the penis that results in the contraction of them. So there's a contraction of them. When they contract, a plot twist happen, which is the collapse of the venous return. So imagine one more again, blood enters, increased blood flow because there is a relaxation of muscle, widening of the arteries. And then at the same time, the venous side is blocked because of a muscle contraction. So blood enters and then it can't leave. So what happens? Blood stays there. So it keeps the erection continuous. And now what terminates erection is the type 5 phosphodiesterase. This enzyme results in the breaking down of cyclic GMP to GMP. So as cyclic GMP decreases, the relaxation decreases. So the blood and the amount of blood that enters into the let's say to erectile body, the blood vessels and the erectile bodies will decrease. Some medications, and the doctor some mentioned some medications that let's say prolong the the erection. So as we know, there's a type 5 phosphodiesterase, basically inhibit. So give the patient type 5 phosphodiesterase inhibitors. One of those subnames is called Viagra. So those results in the prolongation or the prolong the time of erection. So cyclic GMP will long last, and the amount of it will accumulate with increased stimulation. So with that increased stimulation, prolonged presence of cyclic GMP, so in that case, prolonged erection. And that's the transcription of whatever we mentioned. And now the molecular mechanism. Furthermore, we have something that's called the emission and the ejaculation. To fully understand those concepts, they kind of overlap, but they're distinct at a specific point. They're just different from each other. Emission is the movement of semen from the epididymis to the vas deferens, and then all the way to the urethra. So emission, you can just imagine it's the movement of semen within the male reproductive tract. Is that clear? So from the epididymis, which is the starting point of the male reproductive ducts or tracts, all the way to the vas deferens, where it joins with the seminal vesicle, and then the ejaculatory duct enters the urethra. At that point, it's called emission. So from the epididymis all the way to the urethra, the prostatic urethra, it's called emission. After that, when the semen is expelled, or there's an expulsion of the semen from the urethra to the outside towards the female side of the reproductive tract, this is called ejaculation. So emission is within the male body, ejaculation when the semen leaves the male body. And now I think this is the last slide. We have the erection, emission, and expulsion, the 3 E's. This is a quite nice slide that illustrate the 3 functional processes. Let's go over them quickly. We have first erection. What happens? Number 1 is erection, and it's brought by the parasympathetic nervous system, and it's related to the pelvic splanchnic nerve, which is S2 to S4. What happens? What we mentioned previously, nitric oxide is released by a specific stimulus that results in the increase of the cyclic GMP. Increased cyclic GMP will bring the smooth muscle relaxation. Which is smooth muscle? The smooth muscle of the blood vessels towards the side of the erectile bodies. Smooth muscle relaxation, so it means vasodilation. So there is an pro-erectile, so there is a increased in entrance of blood into the erectile bodies. And furthermore, we have something that's called emission. Emission, as we mentioned, which is the movement of the semen from the epididymis all the way to the urethra. And this is related to sympathetic nervous system. So keep in mind, erection was parasympathetic. When we go toward ejaculation, expulsion, emission, it's sympathetic. So sympathetic nervous system related to the hypogastric nerve, T11 to L2. And then we have the expulsion, which is another name for ejaculation. So this is ejaculation. Another name was expulsion. It can be called expelling. So anything that resembles the pushing of the semen outside of the male reproductive tract, it's controlled by visceral and somatic nerves, specifically the pudendal nerve. That's the lecture in general. I hope you benefit from. If you have any question, don't hesitate to ask. Contact me. Here's my phone number and email. Feel free to contact anytime. Thank you for listening and enjoying. Ramadan Kareem.